Hello, this is Dr. Tushar Shah, 16th of July, and we are in the 8th day of our course on outpatient management of COVID-19. One of the most important decisions that you will have to make as a family physician is when to hospitalize a patient. So that is our topic for today, indications for hospitalization. As you all know, the foremost indication of hospitalization in a center which has oxygen and other facilities is hypoxia. Hypoxia is initially, as we all know, happy hypoxia, meaning hypoxia without breathlessness. Saturation of 93 or less should be an indication for hospitalization, irrespective of comorbidities, irrespective of age, irrespective of the clinical status of the patient. Patient might be happy, may be walking around, but you have to admit such a patient. Exception if the patient already has pre-existing lung disease like interstitial lung disease, COPD, then the patient may have a baseline oxygen level of 90% or so, then this patient has to be considered differently. So the foremost indication, hypoxia. The second most important indication is the clinical status of the patient. If the patient has 102 or more fever, I tend to hospitalize. If the patient has more than 6 days of fever, on the 7th day I tend to hospitalize. If the patient is prostrated, is very weak, can hardly walk to the bathroom even on day 1 or day 2, and you have diagnosed COVID, I will hospitalize. So clinical status of the patient becomes very important. I'm not talking about hospitalization for the purpose of isolation. No, I'm talking about hospitalization for the purpose of medically managing the patient properly. So these are about clinical grounds and oxygen grounds. Are there any reports which guide us to hospitalization? Let's take RT-PCR. RT-PCR has this value called the cycle threshold value. The lower the value, the more the viral load it seems. However, never consider the CT value as a criterion for hospitalization. We have seen CT values of 13 and 14 and the patient did not need hospitalization. Also the CT scan. Many people believe that CT scan shows the COVID lung, shows GGOs, must hospitalize. No such thing. GGOs are not an indication for hospitalization. There are some scores on the CT scan points that are given to gauge the severity, cannot be used as an indication for hospitalization. Remember, if the CT has severe COVID, you will see the hypoxia on your pulse oximeter. So pulse oximeter is good enough correlation with the HRCT. So neither RT-PCR nor HRCT become criteria for hospitalization of patient. Now, blood parameters. NLR, high NLR, that is neutrophil lymphocyte ratio, not a sole indicator. High CRP, not a sole indicator. High LDH, IL-6 or ferritin by themselves are not indicators for hospitalization. High D-dimer, if it is more than 4 times upper normal limit, that is, for example, if the normal limit is 500, if you get a D-dimer of 2000 in a patient who does not have any reason for a false positive D-dimer, is proven COVID, I might want to hospitalize this patient because this does indicate a coagulopathy, and any patient whose coagulopathy has started has a worse prognosis than others in whom coagulopathy has not started. This patient I would keep in the hospital, give enoxaparin or something, and probably monitor more closely. So these are the indications of hospitalization. I'm sure this is an area of significant debate. I would welcome suggestions. Thank you.